Hi everyone, this is Dr. Ravindra Maradi, Professor in the Department of Biochemistry, Kasturba Medical College, Manipal. In this lecture, we are going to discuss about the phosphorus. The specific learning objectives are: need to describe the functions, recommended dietary allowance, sources, deficiency manifestations and maintenance of phosphorus homeostasis. And also we need to explain the causes of hypophosphatemia and hyperphosphatemia. The total body phosphorus content is around 1 kilogram. Out of that, 80% is present in the bovine teeth, 10% is present in the muscles and remaining 10% in various compounds, and majority of the phosphorus is present in the form of phosphate. The important sources of phosphorus are: milk is a very good source of phosphorus, and also cereals, nuts, egg and meat are moderate source of phosphorus. Calcitriol increases the phosphate absorption, which is the active form of vitamin D. Requirement for adults, we need around 500 to 800 milligram per day phosphorus is needed, whereas the requirement for children it is more, around 460 to 1250 mg per day, and pregnancy and lactation increases to 700 to 1250 milligram per day because of the growth of the bones in children and also the developing fetus. Normal serum phosphorus level in adults it is 2.5 to 4.5 milligram per deciliter, whereas children the normal level is 4 to 7 milligram per deciliter. Coming to the functions of phosphorus, most important function in the formation of bone and teeth along with the calcium, it forms hydroxyapatite and gives the strength to the bone and teeth. Other function is in the production of high energy phosphate compounds such as ATP, GTP, CTP and also creatine phosphate and phosphoenol pyruvate, where phosphate is added as a high energy bond which is utilized as a source of energy. Synthesis of coenzymes such as nicotinamide adenine dinucleotide phosphate NADP, thymine pyrophosphate TPP, pyridoxal phosphate PLP and coenzyme A, they all contain phosphorus. In the DNA and RNA synthesis, the phosphodiester bonds, where the phosphodiester bonds linkages are formed from 3' to 5' end, the phosphate is an important component in that. Formation of phosphate esters such as glucose 6-phosphate and formation of phosphoproteins like casein. Synthesis of phospholipids, example lecithin, cephalin, phosphatidyl inositol and cardiolipin, we need phosphorus. And activation of enzymes by phosphorylation, that is in covalent modification, phosphate group is added to the enzymes, make it active or inactive, and majority of the enzymes are active in the phosphorylated form. Also plays an important role as one of the important intracellular buffer, that is phosphate buffer system in the blood. At pH 7.4, the ratio of disodium hydrogen phosphate to sodium dihydrogen phosphate is 4:1. Coming to the homeostasis of phosphorus, basically done by vitamin D and PTH, similar to the calcium, it increases the phosphorus level, whereas calcitonin decreases the phosphorus level. Causes of hyperphosphatemia. Hyperphosphatemia is hyper is increased, emia is in blood, increased phosphorus in the blood is hyperphosphatemia. The causes are increased absorption of phosphate, that is in case of excess vitamin D, which enhances the absorption of phosphorus from the intestine and also reabsorption from the kidney. And also in case of phosphate infusion, you can see hyperphosphatemia. Increased cell lysis, like in case of chemotherapy for cancers and bone secondaries, you can see increased phosphate in the blood. Decreased excretion of phosphorus in case of renal impairment and hypoparathyroidism, you can see decreased excretion and elevation of phosphorus in the blood. Hypocalcemia also causes hyperphosphatemia due to increase in the parathyroid hormone and the vitamin D. In case of massive blood transfusions, hyperphosphatemia is seen due to influx of phosphorus into the extracellular space. In case of thyrotoxicosis, increased thyroid hormones cause increased bone resorption. Deficiency manifestations are loss of appetite, muscle weakness, bone pain. Along with calcium deficiency, it causes rickets in children and osteomalacia in adults. Severe hypophosphatemia may result in death. Causes of hypophosphatemia, that is decrease in phosphorus level in the blood, decreased absorption of phosphate, mainly in case of malnutrition, if there is no adequate phosphorus rich food are taken in the diet, malabsorption where there is a problem with the absorption of the phosphate, chronic diarrhea, there is loss of phosphorus in the stool, and vitamin D deficiency causes hypophosphatemia because of the decreased absorption in the intestine and also reabsorption in the kidneys. Intracellular shift. In case of insulin therapy, the phosphorus is shifted inside the cell, leading to hypophosphatemia and also in respiratory alkalosis. Increased urinary excretion, we can see in case of hyperparathyroidism, because parathyroid hormone increases the calcium absorption, whereas it increases the phosphorus excretion. In case of Fanconi syndrome, there is decreased absorption and hypophosphatemic rickets also causes hypophosphatemia. Hereditary hypophosphatemia, you can see there is a mutation in the sodium phosphate co-transporter gene leading to hypophosphatemia. Drugs like antacids, diuretics and salicylates, they interfere with the absorption in the intestine and also increase the excretion in the urine, leading to hypophosphatemia. To sum up, the important sources of phosphorus are milk and meat. Recommended dietary allowance is around 800 milligram is required in adults, whereas it increases in children and pregnancy lactation around 1250 milligram per day. Important functions are in the formation of bone and teeth along with the calcium, Hyperphosphatemia, increased phosphate level is seen in case of excess vitamin D, whereas hypophosphatemia is seen in deficiency of the vitamin D and hyperparathyroidism. These are the references. Thank you for watching.